Greetings to all my followers. I am Professor Momen Mahmoud Hamdi, Professor of Ophthalmology, Ain Shams University. And in this video, I will be discussing the interface between ophthalmology and psychiatry. In the beginning, I would like to express my thanks and regards to Professor Afaf Hamid Khalil, Professor of Psychiatry at Ain Shams University, for inviting me to present this topic at the annual Congress of the Psychiatry Institute of Ain Shams University, which was held in June 2023. Ophthalmology and psychiatry meet and interact in several aspects, including symptoms, ocular signs, medications, and other aspects. This subject has been attracting the practitioners in both specialties for decades, starting from the 70s up till 2023. And even we can find such interaction in the Holy Quran. Bismillah ar-Rahman ar-Rahim. وتولى عنهم وقال يا أسفا على يوسف وابيضت عيناه من الحزن فهو قضيم. صدق الله العظيم. So we can encounter here that the deep grief of the Prophet Yaqub about losing his son Yusuf was reflected on him by severe visual disturbance. This picture is a simple picture designed for non-ophthalmological specialists. Just about a quick reminder of the ocular and periocular anatomy. The eyeball lies within a bony box, which is the orbit, and it is protected anteriorly by the eyelids. The eyeball is linked to the brain by the optic nerve and the different neuro-ophthalmological pathways, and the motility is through the 6 extraocular muscles. So what are the ocular manifestations and phenomena a psychiatrist should be aware of? And what are the ocular conditions that may be encountered in psychiatric patients? So some psychiatric patient may come complaining of seeing flashes of light or seeing multiple dark dots moving and swimming and flying in front of him. This is not hallucination. The flashes of light, this is a symptom called photopsia, and seeing multiple dark spots moving all over the field of vision is called vitreous floaters, and these conditions occur in what we call the posterior vitreous detachment and or PVD. This is a condition in which the vitreous, which is gel in nature, become liquefied due to different reasons, and the remnants of this gel, the patient can see them as these floaters, and during this liquefaction, the vitreous strands, while stretching on the periphery of the retina, induce mechanical stimulation of these photoreceptors in the retina. These photoreceptors express any stimulation and any energy as visual sensation, so the mechanical stretch will be reflected as seeing flashes of lights. So when a patient comes complaining of this, he should not be accused of having hallucination, but he should be referred to an ophthalmologist to make fundus examination. Another symptom is distorted vision. As we see, trees are seeing distorted, these buildings are seeing distorted, and in these squares in the test called Amsler grid are seeing distorted. This is called metamorphopsia or distorted vision, or sometimes there may be micropsia, seeing objects smaller, or macropsia, seeing objects larger, and this is a very famous symptom known by the ophthalmologist to be in macular affections such as choroidal neovascular membranes. And when a psychiatrist meets such a symptom from his patient, he should not accuse him of having hallucination, but he should send him to the ophthalmologist to rule out any organic cause. Also, some physiological phenomena can be encountered by a psychiatric patient, which is called the entoptic phenomena. This condition is seeing small transparent or clear corpuscles or circles moving or swimming on a light background, such as watching the sky or watching a wall with the light color. This is nothing but seeing the shadow of the red blood corpuscles in the capillaries of the retina, and sometimes it is related to some with dry eye also, and the psychiatrist should be not confused that it is kind of hallucination or whatsoever. Also, late twitches, if someone complains of late twitches, it may be due to multitude of factors such as eye fatigue, due to errors of refraction, or not wearing glasses or wearing wrong glasses, the excessive consumption of caffeine, stress, ocular surface irritation by foreign bodies and eyelashes, dry eye, blepharospasm, and electrolyte disturbance. All these can lead to late twitches, and also this may be common symptom for a psychiatric patient. The psychiatrist also should not forget that there are ocular causes for headache, that in migraine there are the visual aura, which are seeing zigzag lines at the periphery of the field. Also, keep in mind that there may be increased intracranial tension with papilledema, and in case of headache, ophthalmological referral is important to rule out such condition. One of the symptoms also that the psychiatrist should know them, and once encountered by on a patient, he should refer them to the ophthalmologist, is diplopia, or doubling of vision, or seeing the object twice. Two objects to be seen for two images for one object. As we see this hand, we see two images for one object. This is called doubling of vision or diplopia. It may be caused by squint and ocular motility disturbances and cranial nerve pulses for the third, fourth, or sixth cranial nerves, and this is called binocular diplopia because the patient will see the object doubled while opening his both eyes. Sometimes some problems can lead to monocular diplopia, which is seeing double vision while opening the diseased eye only, and this occurs with problems in the lens, with a dislocated lens, and also some pupillary problems such as iridodialysis in case of trauma, and polychoria, in which there is more than one aperture for in the eye to get images on the retina, so the patient can see more than one object on opening the diseased eye or the affected eye. Also, psychiatrists should be aware of what is called field defects or scotomata. As we see in the picture up on the right, the field in the right eye is contracted so much that only a small part of the image can be seen, and the rest is darkness, as if the patient is seeing from a tunnel. This is called tunnel vision or tubular field, and this is a manifestation of advanced glaucoma. Also, seeing one part of the central field missing, as we see in the picture down and to the right, is called central scotomata, and this is typical for macular diseases and optic neuritis. So, such a complaint from a psychiatric patient should not be misdiagnosed as only a visual hallucination or seeking attention or whatsoever. Impaired color perception also can occur in optic neuritis, optic atrophy, and color blindness, and it is ruled out by making Ishihara test, and also this is one of the ocular manifestations that can happen to anyone, including psychiatric patients. In psychiatry, it is not uncommon to encounter ocular and periocular infections because psychiatric patients can sometimes be subject for poor hygiene or possible immune compromise. So we can find different forms of ocular infections, such as stye, corneal ulcers, orbital cellulitis, or severe pyogenic infections in the conjunctiva and microperial conjunctivitis. Psychiatric patients also may be prone to trauma, whether blunt trauma, sharp perforating trauma, chemical, physical burns. This may be also self-inflicted trauma in some cases, or as a result of abuse and neglection, especially for psychiatric patients without proper care. Maybe also liable for foreign bodies within the ocular surface or intraocular foreign bodies. And we can see here multiple pictures of different aspects of trauma, as subconjunctival hemorrhage, blood in the anterior chamber, which is called hyphema. Cataract may occur from a severe blunt trauma, and here we can see in bottom to the right a ruptured lobe, and above there's an alkali burn. All these forms of trauma can not uncommon to be encountered in psychiatric patients. There is also an important interface between addiction and ophthalmology. Addicts may be prone to ocular candidiasis, may be prone to HIV retinopathy or air embolism and central retinal artery occlusion from the bad use of syringes. Heroin sniffing is related to rhino-orbital mucormycosis. Some motility disturbance and nystagmus are related to chemical abuse. Cataract. Marijuana is related to glaucoma. Alcohol and smoking are related to optic neuritis in what we call tobacco-alcohol amblyopia. Methyl alcohol poisoning is a very dangerous condition in which there is extensive bilateral optic atrophy with loss of vision in both eyes, and it can be and it's not uncommon to encounter. Cocaine smoking is also related to cracks in the cornea. And lastly, medication side effects have been famous in the practice of psychiatry through decades, starting from the 1950s with the congenital ocular defects that were caused by thalidomide. Also, drugs with anticholinergic effects such as SSRIs and tricyclic antidepressants may lead to glaucoma and angle closure glaucoma. Other diseases such as cataract, dry eye, corneal endothelial pump problems are related to many different psychiatric medications. Topamax or topiramide is a very dangerous drug that may lead to bilateral angle closure glaucoma from severe coleochoroidal effusion. Phenothiazines are related to retinopathy. Nystagmus and also motility disturbances can be caused by some psychiatric disorders, and there are a multitude of side effects from psychiatric medications, and this is very important to have a cooperation between the psychiatrist and ophthalmologist while using chronic medications for years and years to avoid such complications in the eye. Recently, some ocular investigations are of interest for psychiatrists, such as the OCT. In schizophrenia and bipolar disorders, OCT can detect some retinal cytoarchitecture abnormalities. The VEP is important to study the integrity of the optic nerve and the visual pathway in convergent disorders and malingers. Video nystagmography is important to detect the saccadic abnormalities, which is a neurobiological markers in clinical and preclinical schizophrenia. The SEBR, or spontaneous eye blink rate, is important for the diagnosis of post-traumatic stress disorder. Now I shift to the second part of the presentation, which is the relation between ophthalmology and psychiatry, or what are the psychiatric aspects an ophthalmological should be aware of. So, abnormal eye appearances such as the squint, big eye in ophthalmos, primary congenital glaucoma, ptosis especially in children, microphthalmia, small eye, anophthalmia, lack of development of the eye, scarred cornea, proptosis, and any abnormal appearance of the eye may be related to stigmatization in the society, bullying, especially in children and adolescents, and low self-esteem. So the ophthalmologist should be aware of these problems while dealing with the ocular problems, and he should be seeking a psychiatrist help if these problems are very prominent in his patient. Psychological factors also may aggravate and cause certain ophthalmological disorders, and these are called the psychosomatic diseases of the eye. And the very famous is the central serous retinopathy or central serous chorioretinopathy, in which there is fluid accumulation leading to such appearance in the OCT. Also, glaucoma can be sometimes said to have some psychosomatic disorder, to be a psychosomatic disorder. Styes, retrobulbar neuritis, Sjogren's syndrome, all in some theories have some psychosomatic aspect. Hallucination or visual hallucination is the perception without external stimulation of relevant sensory organ. The ophthalmologist should be aware of visual hallucinations. Although traditionally visual hallucinations point toward a functional psychosis, in reality they occur more frequently in organic states than psychiatric conditions. Visual hallucinations can occur transiently with post-operative delirium in cataract surgery. They can be caused by drug and alcohol withdrawal. They are accompanied in psychiatric disorders usually by auditory hallucinations and other signs of mental illness, and they are common with dementia or emotional stress. Occipital lobe tumors, epileptic seizures, and migraine attack are also related to visual hallucination. So, while encountering visual hallucinations, organic ocular cause and neurological cause should be ruled out. Hallucinations can be just simple in the form of flashes of light, pattern, color lines, geometric shapes, or complex in seeing people, seeing objects as cars, and seeing animals. Charles-Bonnet syndrome is a condition in which there is vision loss and visual hallucination. Charles-Bonnet syndrome occur with severe bilateral visual loss. It is generated in the visual cortex when normal incoming sensory impulses are absent. It follows visual loss by days or weeks and can last for a few seconds or minutes or can be continuous. It takes place in the evening and night when lighting is poor and patients are inactive or alone. It's in the form of patterns, letters, people, animals, objects, landscapes are seen with sound, sometimes with auditory hallucinations. They are generally well tolerated and only require reassurance about their benign nature, and they are avoided by increasing the social contact of the patient and avoiding isolation to tolerate these hallucinations. Ophthalmologists also can be should be familiar with the psychiatric aspects of eye surgeries. Preoperatively, we should be well familiar that it should be very important to know that the patient has an anxiety. Some patients are afraid of investigations, are afraid of pricking needle around the eye in case of local anesthesia, are afraid of not waking up in general anesthesia, are afraid of fear of blindness. So preoperatively, we should respect this aspect and this should be important while dealing with the patient. In order to have a proper intraoperative scenario, to avoid some problems such as phobia of touching the eye in case of LASIK. Claustrophobia also can occur from draping in intraocular surgeries. Panic attacks with local anesthesia can occur. And as we all know as ophthalmologists, a second eye is always difficult because the patient is alert and aware of what he will submit. So these are all important psychological aspects that should be well respected intraoperatively. Postoperatively, psychological reaction and psychiatric complications are also well known after cataract surgery. Some deception can occur if there is a delay in the improvement of vision and so on. Black patch psychosis, it's not common nowadays. It's a condition that occur, psychosis which occur when both eyes are patched after intraocular surgery. It's a faulty adaptation to psychic stress and visual deprivation and loss of perceptual and conceptual clues. It occurs more in cases with hearing impairment. It is in the form of restlessness, hyperactivity, anxiety, irritability, disorientation in time and space. So it's important not to patch both eyes as much as we can, and maybe also presenting less frequently by mania, delusion, auditory and visual hallucination. Ophthalmologists also should be well familiar with the psychological state in blindness for his patients, because the blind patient can suffer from depression, anxiety, personality changes, communication problems with the society, emotional distress, and of course, it is more common with elderly and patients who live alone, and even the caregivers, even the caregivers can also be at risk. Not only the patient, but his relatives, and also the psychological state of our blindness in children has a very serious impact on developmental delay and learning difficulties. The link between neuroophthalmology and psychiatry is important. Non-organic visual dysfunction can be detected by the functional integrity of the visual system and the non-physiologic nature of the visual complaint. Organic dysfunction may occur with a presumed psychiatric diagnosis. Pathology may be related to the psychiatric medications. CNS pathology, whether neoplastic or infectious, should be ruled out. And briefly, ocular examination, including motility, field assessment, and neuroimaging, are required to establish the link between neuroophthalmology and psychiatry and to detect whether it is a pure psychiatric problem or there is an organic cause. One of the famous relation between ophthalmology and psychiatry that we used to encounter during residency was the psychogenic or functional vision loss or hysterical blindness. Hysterical blindness is vision loss that is unilateral or bilateral in absence of any organic cause, whether refractive error, ocular media disturbance, retina, or optic nerve. It is more common to occur in convergent disorders and also in malingerers. And it's more common of psychogenic visual loss to occur at the children with the children and young females. Malingerers are usually adult males seeking financial gain or compensation in accidents or insurance issues. Hysterical blindness or psychogenic functional vision loss can be manifested by in the afferent system with impaired visual acuity, impaired visual field loss, or hallucinations that is the picture that the patient is presenting to us, or even in the efferent system with ocular motility disorders or pharmacological factitious pupillary disturbances, eyelid position and function, corneal and facial sense. Other corneal and facial sensation and voluntary nystagmus. So briefly, that the conversion disorder can be in the form of afferent problems. The patient can be complaining that she is blind or he is blind, whether conversion disorder or malingerer, and also some ocular spasm and ocular motility disturbances and blepharospasm can be manifested on such patients. So how can we prove that this is a hysterical blindness or this is a malingerer? By the reactive pupils, as we all know, by professional visual acuity assessment, and by the VEP to exclude any organic problem of the visual pathway. Even the eye drops are mixed with the psychiatry. From the chronic use of eye drops, there may be some psychiatric effects, and some drops, such as the beta blockers, are linked to depression, lethargy, and loss of libido in case of the chronic use of beta blockers in glaucoma. Allergy from eye drops can cause irritability. Frustration and anxiety in elderly can be encountered from the difficult use of droppers and lack of compliance. The ADHD, the attention deficit hyperactivity disorder, is also a condition that is recently famous in the society, and it has some interface between the ophthalmology and psychiatry. Strabismus is associated with ADHD, errors of refraction and amblyopia as well, accommodative spasm, convergence insufficiency, defective color perception and contrast sensitivity, and involuntary eye movements and eye tics and blinking are all possible ocular problems that can be encountered with the ADHD. So this is a condition in which the ophthalmologist will have some intuition that the child that he is examining have ADHD and can refer to the psychiatrist to prove this diagnosis. So as a conclusion, the practice of ophthalmology and psychiatry meet over in several aspects of the patient diagnosis, management, and therapy. Psychiatrists should be aware of ocular conditions requiring ophthalmological consultation, and meanwhile, ophthalmologists should not deny many psychiatric aspects in their patients, which may affect the compliance to medications, the smoothness and success of interventions, whether investigations or surgery, with the possible need of help from a fellow psychiatrist. And here I come to the end of my presentation, and I thank you for your attention.